Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is March 26th, 2026. And the title of this podcast is This One Goes to 11, ATLS 11th edition. And our guest skeptic for this 11th edition of ATLS is Dr. Robert Leeper, a trauma surgeon at the London Health Science Centre and an ATLS instructor who has helped train a generation of physicians in trauma care. And he's also joined us previously on SGEM episodes. Welcome back to the SGEM, Rob.
Happy to be here, Ken. You should add, if you want to just for content and to match today's theme, I'm also the Ontario Virtual Chair for the ACS Going on Trauma, and so ATLS is a huge part of my life and my practice. I think that's it's an 11th edition is a big change for us. So yeah, I'm really excited to be here and talk about it.
Well, and why don't you say where we're actually recording this? Because usually we do it at Moose Manor or at the Bat Cave, but today we are at
just in my office. Not nearly as fun as the Bat Cave, but I'm on a bit of call, so it's good to be here.
Yeah, so I traveled down to Victoria Hospital, part of London Health Science Centre, and we are in his office where he has a fridge stacked with caffeine and a old leather couch. Well, this is an SGEM Extra, and we are going beyond a single paper and diving into a broader topic, and that impacts our daily practice. Now, some of you may remember back in 2018, we did a top 10 list for ATLS 10th edition. Yes, we cranked it up to number 10, and I will put in a list in the show notes, a table there of the top 10 changes we discussed with Dr. Neil Perry.
Yeah, but today, that was an awesome paper with Neil in 2018.
He does go to 10, and when it comes to dressing, he's a sharp dresser, that guy.
But today we're going even beyond that. We're not going to stop at 10. We're going all the way to 11. And if you don't get the reference of going to 11, I'm sure you can go and watch in the show notes the clip for This is Spinal Tap, a mockumentary about a fictional rock band whose amplifiers go to 11 instead of 10. And when asked why, they didn't just make 10 louder. The guitar supplies, these go to 11. And it is important now. It's a Rob Reiner film and a sad time that we lost him this year. So I think an appropriate topic.
Yeah, it was kind of sad to hear about Rob Reiner's tragic death and timing with the 11th edition, so I thought it was a nice way to recognize him. So do you remember, because I mean now you're way up in the echelons of ATLS, but do you remember when you first took ATLS?
Like it was yesterday. June 28th, 2007. It was the day before, the week before I started residency.
Oh, okay.
Here at C-Star. Had to be about 8th edition back then.
Oh, 8th edition. Well, let's time travel here. I took ATLS way back in 1995, and it was my favorite number edition. Number 5. That's right. I took the 5th edition of ATLS way back 31 years ago. But you eventually became an ATLS instructor. How many editions have you lived through then?
Yeah, that's a skill testing question I don't have the exact answer to, but I would guess about 3.
I think I've done about 3 as well, because I started much after in my career than you, being an ATLS instructor. And that's where we really got to know each other. For those out there who don't know the history of ATLS, can you give them just a brief backstory of how it started?
Yeah, sure. Necessity is the mother of invention. And sadly, a surgeon by the name of James Steiner had a plane crash. He was kind of like John Denver, who was on a plane, crashed in a cornfield in, I want to say, Nebraska. And it was terrible. His wife died on scene, but his kids who were in the plane with him survived, but were badly injured. And what he noted is that when they arrived at the small hospital in Nebraska, there wasn't a common language of trauma care. The care was disorganized and episodic. And he thought, we need to do better at putting together a common playbook for everyone, from the small centers to the biggest, to work off.
Yeah. We don't want to disparage small rural hospitals, given that that's where I work.
Exactly.
But I think that this was a general sort of thing, that trauma care wasn't so organized. It was sort of a little haphazard back in the 70s. And emergency medicine was just starting as a discipline. So I wasn't surprised. And Stainer later said, quote, "When I can provide better care in the field with limited resources than my children and I received at the primary care facility, there is something wrong with the system," end of quote. And that moment led to the development of a structured approach to trauma, one that could be taught, replicated, and standardized.
Yeah, and so the first ATLS course was put together and eventually delivered through the American College of Surgeons in 1980, and it emphasized something, I guess, kind of radical at the time, a really just systematic approach, making, initial assessment the priority, airway, breathing, circulation, disability, the ABCDEs, exposure in the last one, that we all think of as second nature now.
It's just one more great thing that came out of the 1980s, the best era. But in emergency medicine, we have our own alphabet. It's not A, B, C, D, E like it is in ATLS. Our alphabet is A, B, C, T. That's right. Send them to the donut of truth. But back to the 1980s, this systematic approach with the A, B, C, D, E wasn't about memorizing injuries. It was about preventing death from the first thing that kills. And over the decades, ATLS became one of the most widely adopted trauma education programs in the world. It has trained hundreds of thousands of clinicians in over 80 countries.
And like any good long-running franchise, it has to improve over time. Star Wars, Mission Impossible, Star Trek, Batman, each new edition is supposed to be a little better than the last.
Yeah, and some people listening might argue that Star Wars and Star Trek did not improve with time. Batman, yeah, maybe, but Star Wars and Star Trek, maybe not so much. So today, instead of the top 10 list, as we did for ATLS 10th edition, today we're going to go with the 5 most important changes in ATLS 11. So 5 is my favorite number because I can count to it on one hand. I love the number 11 because, of course, it goes to 11, that giving it that little extra. And then I like this really round number. Oh, that's right, 0, 0. So because sometimes less is more. And even if the amplifier goes to 11, today we are going to go to 5. And so here are 5 changes in the ATLS 11th edition. And the first one is, this is the xABCDE. Hemorrhage now comes before airway. This is the most noticeable clinical change in ATLS 11, and it's the addition of this X. Oh, we are becoming part of the X-Men team or something. To the ABCDE, we are making it xABCDE, with the X standing for exsanguinating hemorrhage. Massive external bleeding is now formally prioritized over the airway management in select patients. And while many trauma teams have already internalized this bleeding kills first principle, especially after a decade of military to civilian trauma translations, ATLS has now codified it in the 11th edition. In practical terms, this reinforces early tourniquet use, direct pressure, hemostatic adjuncts as first-line priorities when appropriate. It's less of a revolution and more of an official acknowledgement that the world of trauma has already turned the volume up on hemorrhage control. But formalizing it the way they have done in the primary survey does matter, because what we get taught gets practiced.
Yeah, I mean, you'll have to cut me off because I will literally talk until every listener turns this podcast off about exsanguinating hemorrhage. Bleeding is the enemy.
Bleeding bad.
Yeah, putting the X out front, like with the X-Men theme music, is super important. They're back in Marvel now, and it's back to the forefront of trauma care. I think just a couple of brief thoughts on it. The American College of Surgeons is doing everything in their power to put that out. Our Stop the Bleed course has trained millions of people in targeted civilians using things like you said, tourniquets and gauze, and we're putting kits beside AEDs in public places. And certainly as we train providers in trauma care, X comes first, and we are really moving the needle and swinging the pendulum to a degree where now a lot of our sort of aftermarket surveillance is on how do we get tourniquets down sooner? They're being put on and sometimes too much, too early, left on too long,
and forgotten.
And so it really is a big shift for us, and it's almost like what's old and new again. If you ask somebody in the Middle Ages, what do you die from injury? It's the blood that comes out. And now we're just getting back to the idea that that actually is the number one cause of preventable death early after injury. So
it's a little similar to maybe ACLS, where out of hospital cardiac arrest, it's if you have a shockable rhythm.
Mm.
right? You've got a chance. And so we see AEDs in lots of different places. You know, if you're going to have an arrest, an out of hospital cardiac arrest, you want to be in a Vegas
Airport, casino.
casino, a hockey rink in
Mm-hmm.
Canada, like you said, an airport. And so now you see the AEDs. Now you're saying that there are going to be these little kits with tourniquets in there to address
Oh
bleeding.
yes.
I haven't seen those yet.
Yeah, they're out there. Yeah, there have been a few like logistical issues around it, but we are delivering self-bleed courses from this hospital and putting kits out there in schools and arenas and certainly south of the border, it's being done even more so. Putting out there on public places to go alongside EDs as for civilians to break in case of emergency and put this on if you see it.
Wow, this is so it's like simple things like electricity for a shockable rhythm, a tourniquet to stop bleeding, and maybe some naloxone for opioid overdoses. Simple things,
Mhm.
simple maneuvers, not the fancy. And, you know, we've talked about things like Raboa and stuff like that before. This is simple things that, you know, bystanders could do
Big
to save lives. What's the second change that's in our top five list?
Yeah, I love this one too, Ken. It's one that I think is close to my heart, and we and I have been harping on for years and years. And it's all about hemodynamic optimization prior to intubation, which I think is so important. So it's another it's subtle, I guess, but really important change in the 11th edition, and that they're looking at saying, hey, really work on fixing shock first before you move to RSI. You know, ATLS 11th edition hides the risks, and they're huge, of peri-intubation hypotension and arrest in somebody who's unstable from trauma. We're working to encourage clinicians, docs, nurses, providers of any kind to try their very best to put that X first, correct the hypovolemia first before you take the airway.
So you optimize the patient before, if you have to take the airway, because, you know, often when we do grab the airway, we lose hemodynamic stability or we lose some kind of
Uh,
blood pressure control.
No, it really and it does. It aligns with I think what everybody from emergency medicine to critical care, anesthesia, is talking about and working in the context of, hey, there's a danger to a precipitous airway management situation in shock patients. So let's really think about physiology first. Use non-invasive means to support oxygenation, ventilation, and then really make your first shot your best shot and avoid. It's a nice way to get a thoracotomy if you're looking to do them in the emerge, but we really would discourage that to happen. That's actually Joe for force. And I just think it behooves us all to think in terms of things that are simple, like, hey, does this patient need their airway managed down here, or could we do it in the operating room?
Little controlled situation.
And certainly, paralytics are going to achieve ideal conditions immediately. So how much sedative or analgesic do you need? You don't want to kill someone with kindness. We always used to say, "Oh, don't give vasopressors in trauma. If you do, it's because you're failing to get enough blood." Okay, I mean, I get that, 100% do, but using vasopressors to support, afterload in the setting of, a high risk intubation and medication, 100% agree with that. So all these subtle changes, I think, are really important, and this will, just like xABC, this will save lives.
Yeah, so it reminds us that the airway isn't just about the anatomy, it's about the physiology of the patient that you have in front of you. The third thing that we wanted to talk about is the major structural reorganization and system focus. The changes to ATLS 11 aren't just clinical.
Mhm.
The edition reorganizes the manual into three major sections. It looks at resuscitation, trauma system context, and specific injury patterns. More notably, it introduces full chapters on trauma system injury prevention, trauma-informed care, and communicating serious news. And this reflects a broader view of trauma care that extends beyond the primary survey. ATLS is no longer just about what happens in that first 15 minutes, or they talk about trauma, the golden hour, and those type of things. But other things need to happen. For instance, this may feel like we're expanding into the world of public health. Whether that's an evolution or mission creep may depend on your worldview, but it's clear ATLS is trying to move from protocol to a platform that it can address the whole system that takes place for trauma.
Yeah, I think this is a big deal, and it may not be as immediately patient-centered, impactful, like individual patient as parent inpatient hypertension or XABC, but that broader system-wide view trauma systems, oh my gosh, like read,
It's about systems. It's about systems. You've got to make sure it all flows. It's about the flow through the system.
and no one needs to pump his tires, but boy, probably our preeminent trauma surgeon in Canada is Avery Nathans, and his papers are so interesting and impactful about trauma systems.
Say his name again. We need to hear it twice.
Avery Nathans. And the way he looks at like under triage, over triage, secondary transfer, it makes massive difference in patient outcomes. And everyone knows, wherever you work in the world, how you engage with your local ambulance service, your air ambulance, how smaller referral centers interact with bigger ones. This is a huge deal. So
You work in a trauma center, a level one trauma center, and you're on the receiving end. I'm on the, hey, Rob, it's me. I'm up in wherever.
yeah.
And you know as well as I do, when you get into the flow state, and I'm working with some nurses and maybe an RT and some other allied health professionals, and we're working together. And then I reach out to you and we have that connection and it all flows. And we've also had the times where, oh, it's a dumpster fire and everybody doesn't seem to be working together on team patient. And so I think systems are so important.
Yeah,
So
again, system-wise, I could talk all day about that. We should just briefly mention for the audience, the other items that are newish under that is systems sort of
umbrella.
So, injury prevention. We at our national trauma meeting, we give awards every year for best IP paper. We have 2 or 3 people hired full time just to do intervention with us, right? It's a big deal, and so it's like that whole public health model. If you can go further upstream and keep people from falling in the river, you have less job for lifeguards pulling them out down the road. So I think that's huge. Social determinants of health, enormous. Looking at trauma, whenever you pick out any place in the world and graph out mortality from heart disease, cancer, et cetera, you look at trauma, and any equity-seeking group is going to have 5, 10, 20 times the higher rate of injury from trauma. So this is a very equity-seeking and socially minded group as a trauma surgeon. So I love that it's becoming a formalized part of our course. And the last piece, communicating serious news in acute care setting. That probably is some hybrid of what, if you went to med school in the olden days, like myself and maybe you can, that would be like breaking bad news. Putting in, CRM, crisis resource management, as part of a dedicated teaching module in ATLS. These are 2 related and super important ways to be a better trauma provider.
And I remember it was criticized as, oh, well, that's the soft science. When people have a loved one die and you're communicating that news, that is so important. This is what they're going to remember. They're not going to remember if you activated the massive transfusion protocol, how many units of blood you gave, whether you started vasopressors, what size of the ET tube was, blah, 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 blah. How did you handle that critical conversation that they're going to have imprinted through a very psychologically traumatizing experience? And are you trained to do that well? Because there are techniques that can improve those communications of serious news.
No doubt. We should probably go on to the 4th point.
Let's hit number 4.
Which is near and dear to my heart. A dedicated penetrating trauma chapter in ATLS. And I think it's worthwhile pausing here, just to reflect on the fact and that you've worked in emergency departments all over Southern Ontario for how many years now?
So all over Ontario. I mean, I've been up to Lake of the Woods, Kenora, all the way over to Pembroke, down to Leamington and everything in between. But for about 3 decades now. Yep.
And it was just in the past year or so that you saw, after 30 years, your first ever gunshot wound.
Yeah. I've gone around saying, oh, I've been a Canadian emergency physician for, this many years. And the number of GSWs I've seen is a nice round number, 0. Well, after about 3 decades, that number is 1.
Something to say again, a little louder for those in the back, an incredible statement about, we are so fortunate to live in a world where thankfully this kind of injury is rare, but not everyone in this world is so fortunate.
You send your residents, don't you, out of country for fellowships or for training to look for penetrating trauma?
Yeah, I mean, I went away to Baltimore to Johns Hopkins for my fellowship because for a number of reasons. But yeah, one of them is that you simply can't get a high enough volume of penetrating trauma exposure in most Canadian settings. And so it is unquestionably though a worldwide massive problem, like epidemic levels throughout the parts of the world. And so recognizing the fact that although all injury is injury,
There's a
there's
dichotomy
a
there,
dichotomy in the
between
world.
penetrating and blunt, right? And
100%.
some countries may have better expertise at blunt, and I see a lot of blunt trauma, and I don't see penetrating, whereas other places might see a lot of penetrating and not so much blunt.
So I think it's fair that penetrating trauma now has its own standalone chapter in this edition. And it kind of recognizes that penetrating injury has its own unique considerations for management, and that in the new edition, we're really emphasizing, mechanism-driven evaluation. Was it a gunshot? Was it a knife? Was it, and focusing, I think, appropriately so on utilizing more non-operative management and updated surgical kind of decision-making paradigms. And for American trauma systems, this is particularly relevant given the epidemiology of gun violence we talked about. GSWs are unfortunately the leading cause of death in the U.S. for children aged 1 to 17. And the key question, from an SGEM lens would be is whether the content fully reflects contemporary evidence, especially regarding selective non-operative approaches. But structurally, this is a meaningful shift that gives penetrating trauma its own, I guess, like intellectual real estate.
Yeah, for SGEM listeners, most of us are frontline working in emergency departments. And so that nuance of whether it should be surgically approached or non-operatively approached would be more on your plate as a surgeon.
Yeah.
So, a little bit beyond the scope here.
Mhm.
But bringing up the idea of GSWs and blunt trauma versus penetrating trauma really leads into the fifth and final point. And this is about flexibility. Having a global adaptation philosophy, one size doesn't fit all. And this manual explicitly acknowledges global variability in trauma resources. Some places have CT scanners available. Many of the places I don't. Some of them have blood products. Some of them have massive transfusion protocols. I like to joke that, many of the places I work in, the massive transfusion protocol is, oh yeah, we gave them both units of O neg, because that's all we have. We have 2 units of O negative at some of these places, and we don't have access to specialist care like trauma surgeons, anesthetists. It's just a primary care physician working in a rural emergency department or an emergency physician working in a community setting with single coverage.
Mhm.
So ATLS now encourages adapting principles to the setting rather than assuming everyone's a level 1 trauma center and everybody can do everything. It really recognizes that trauma education must be globally applicable, and it moves ATLS from a rigid protocol towards a framework. And it reminds me of my evidence-based medicine, my EBM mentor, Dr. Andrew Worster, who said to me, the answer is, it all depends. And trauma takes place in a context. It can be rural, urban, remote, academic, community, low resource, high resource, all of these different situations. And how ATLS is applied in your clinical situation will depend on many factors and requires flexibility.
Yeah, it made me think. I was just at our annual Committee on Trauma meeting, and I was giving a talk on a panel with Alicia Brownson, who's a trauma surgeon in Alaska, and she was talking about our RTTDC course, which used to be called the Rural Trauma Team Development Course. It's been renamed the Resource Variable.
Ah.
And it's a really important course that honors and reflects the fact that it isn't just rural communities, but small urban communities. You can imagine lots of reasons why different areas have variable resources.
It's on a spectrum from I don't have anything but, maybe a clamp and my own blood, and all the way up to a level 1 trauma center like you work in.
Building in the idea that, hey, this is the playbook, but you're going to have to modify the standard and what you're going to do depending on your setting. And that's I think that's smart to make ATLS more of a an applicable and universal, truly universal tone and course for every trauma care setting.
So, Rob, that goes through the 5 things that I pulled out, but is there any other changes that you think we should mention?
I think we're still really leaning in on less crystalloid for sure, and more blood, which was part of the 18. The other big change in 18 that I think has only been like doubled down on or double clicked on is some of our pedagogy stuff using, I guess this is like Betsy Hunt's principles of rapid cycle delivered practice, RCDP, saying we're going to walk you through a skill, talk you through a skill, have you show us, have you show somebody else. Those various phases of the pedagogical approach to adult learning. That's been a bigger deal. In our ATLS 11th edition instructor course, we're now adding an extra practice and then a performance station for all of our, skill stations, our financial assessment stations, and our interactive discussion stations. So a little more heavy into teaching and teaching styles and really focusing on adult learning theory. Those are the big ones I have written down. Anything else you were looking at?
Yeah, so they combine the head and spine together into disability under the
Yeah.
D.
Smart.
I like the fact that they expanded this section on geriatric trauma, seeing that I'm getting closer to that age where I might be defined as geriatric.
Mhm.
And, our population is aging, at least where we work. And so majority of the patients I see are older. Talking about enhanced communications, I like that. We already talked about, this xABCDE, but they've updated the transfer mnemonics to SXABCDE dash bar, and we can talk about that. The hybrid learning that you talked about.
That was the big thing for us, Ken, is that, in 2018, we finally did away with lectures, that they became in our discussions.
Yes.
And now, I mean, I don't know what the numbers are worldwide, but nationally, the great majority of courses in Canada are delivered as hybrid courses, which means that there is no interactive discussion being done live. It's all being done online before you come. So a big change, I think, with 2018 10th edition, and now even more so now, we're seeing a lot more pre-course online learning that's being done before.
Would that be a little bit like flipping the classroom? So, like giving stuff to the participants in advance, checking where they're at, giving them some interactive stuff online, and then arriving for taking it to the next level.
100%. And I will say, if people are listening and are concerned, if they've done 11th edition course, our pre and post tests that we did weren't the best. They're being changed. We're modifying them. They're coming in with better tests coming out very soon. That was another update we had at COT just last month.
I dropped in there this whole idea of the SXABCDE. I was wondering if we could walk through that together. What does the S stand for?
Situation. So sort of like, who and where and why. You get like your name, where you're calling from, the patient demographics, and sort of the mechanism that they were injured by.
So it would be like, hi, this is Dr. Milne. I'm an emergency physician working at Rural Route Hospital number whatever. And I have this patient. Here are the demographics. They were in a tractor accident or fell off the loft of a barn. And I think I need to transfer them for X, Y, and Z reasons.
Yeah. And then I think, it sometimes feels a bit pedantic, but I do think it's cool to say, I'm just going to quickly pause and go over my xABCDE for this patient.
I think it helps organize our thoughts because there's often a lot of adrenaline running through. You've just spent some time with that patient. You have them in your head, but you're calling someone who's just picking up the phone. And it's nice to orient them and that you're speaking the same language. Okay, I'm just going to walk through this xABCDE. So walk me through the xABCDE.
Yeah, I'll give you a good example. And as I will say for anyone on this listening to this who is a receiving end person, this is the phase where I kind of like might manually bite my tongue and make notes. I don't want to interrupt people.
Yeah.
Finish what you're going to say. I'll just make little notes of, I need to ask about this. I need to go back on that. So, but as an example, I might say, hey, doc, let me run through my XABCs. X-wise, there was no external bleeding. The tractor kind of mashed him, but he wasn't bleeding too badly outside. Airway, it is patent. He's talking to me. No blood in the airway. Breathing wise, I was very worried. Maybe he's got a really tender chest on the left, especially some subacute air there. His chest X-ray showed pneumothorax, and I placed a chest tube. It's a 28 French. It's in it. Circulation wise, he has been soft. Pressure's more in the high 90s, low 100s. We've got 2 IVs running. He's in a pelvic binder because the X-ray showed some changes in fractures in the pelvis, and he's given TXA a couple of grams, and we've given our massive
both units,
and we're hoping to come down to you soon. Disability wise, he is GCS 15. People are more active with light. And exposure wise, I've rolled him back and forth. I've seen all his extremities. He's not hypothermic. It's the same thing. It's a warm summer day, but he's covered up with to prevent hypothermia. And I did not just deal with hemodynamic survey. I identified an extremity fracture that I stunted.
So that gets us through the S, which is the situation, and then that xABCDE, that primary survey. And then the final component is raising the bar. That's the BAR. What's the BAR stand for?
Just background. This is sort of like the standard stuff you've been doing since your first day of med school, like past medical history, medications they take, particularly anticoagulants are a big one there, right? Allergies and kind of baseline function. He lives in a nursing home, or he was running a marathon yesterday.
That's different. Yeah, yeah.
Yeah.
And then the A?
Yeah, assessment. So kind of just naming now after all that, what do I know for sure? I know he has a flail chest. I know he's got a chest tube from the thorax. I know he has a fracture implanted, right, distal radius. And my working diagnosis is hemorrhagic shock from internal bleeding from potentially a spleen. And that's my concerns. I'm giving him blood and sending him your way.
And then the R for the bar?
Yeah, recommending what he needs. Transfer to definitive care, cross-sectional imaging, surgical consultation, the operating room, the ICU, etc.
Yeah, so that takes us through this S, X, A, B, C, D, E bar. And what I'll do is I'll put a table in the show notes, and this could be a useful table just to keep on hand if you're working out in the periphery, or if you're at the receiving trauma center. It'd just be nice to have someone, like you said, you take notes. Well, here's a nice little table. You go, oh yeah, we covered that. Yeah, we'll cover that. Okay, I need to circle back. You did put in a chest tube because you mentioned that he had a pneumo. So, things like that. Just to make sure we have faithful communication of the information.
I like how's it secured too. Communication, I think, of chest tubes is that they get pulled out and transferred.
Oh, okay. Well, there we go. There's a little pearl. Okay, well, that wraps it up. Why don't you give us an SGEM bottom line?
Yeah, so I don't think that the 11th edition is radically reinventing trauma care, but it's formalizing some important things. Like, number one, thinking of hemorrhage first. Put that X up front. We're now the X-Men. We're looking harder at number two, expanding system-based care, injury prevention, transportation, all those important things. We're modernizing the structure and teaching, focusing on, adult learning theory and educational principles. And last, I'd say it's recognizing global variation, like our RTTDC course, Resource Variable Trauma Care, is important to kind of honor and enshrine in the primary ATLS course.
Yeah, so making sure that its external validity applies everywhere. Well, the SGEM will be back next episode with a structured critical appraisal of a recent publication. Our goal is to shorten that KT window down from over 10 years to less than 1 year by leveraging the power of social media so patients get the best care based on the best evidence. Well, thanks, Rob, for co-hosting another episode.
Yeah, always my pleasure, Ken.
And Rob, can you give the SGEM tagline?
Yeah, remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.
Talk to everyone next time.